Hi everyone, welcome to researchmd.com. Another great presentation today. Let me introduce myself. My name is Dr. Pramil Cheriyath. I'm a physician practicing in the United States, a program director, internal medicine residency and the transitional residency. I'm also an associate professor of medicine, two large medical schools in the United States. So we've been doing a series of lectures on endocrinology. We covered a lot of hormones. Today, a big topic, okay? Adrenal insufficiency. That is our topic today. We're just going to go through from the causes, the pathophysiology, and the treatment, and how to diagnose. The most important thing is how to diagnose, okay? So let's start our presentation today. We're going to look at, anytime we do our presentation, first thing we need to do, we need to look at the definition, okay? So what is the definition today of adrenal insufficiency? You can read up here, deficient production or action of glucocorticoids with or without deficiency, also in mineralocorticoids and adrenal androgens. You definitely going to have glucocorticoid deficiency, but it does not have to be mineralocorticoids or androgens. Okay, remember, so always going to be glucocorticoids with or without mineralocorticoids or androgen. That's the thing we need to know. Let's look at the causes. Before we look at the causes, I think is to understand like some classification. We need to know primary adrenal insufficiency, secondary adrenal insufficiency, and tertiary adrenal insufficiency. Okay, now let's look back and look at where the adrenal gland is situated first. Where is it situated? On top of the kidney, bilateral, remember that. Okay, so right now over here, this is our adrenal gland, which is sitting on top of the kidney. So anything goes over here wrong, that is called primary adrenal deficiency. So main thing it happens is in the adrenal gland. So I'm going to put right here, right? So this is the pituitary, this is the hypothalamus, this is the pituitary, and this is the adrenal gland, which is sitting on top of the kidney. So only problem is down here. Everybody got that? Now, so that is called a primary adrenal insufficiency. Now let's look at the causes for that. We look at autoimmune is the number one cause. You got autoantibodies produced against 21-alpha hydroxylase enzyme. Remember that, okay? And then look at the other causes, infections, TB. TB used to be the number one cause before, right? If you look at worldwide in 50 to 100 years ago, TB was very predominant, not anymore. So that has come down. So if you have to pick one cause of primary adrenal insufficiency, I always go with autoimmune number one, okay? Again, don't forget the infections, TB, HIV, fungal adrenalitis, syphilis, and all of this thing can cause primary adrenal insufficiency. Bilateral adrenal hemorrhage, bilateral adrenal mets, bilateral adrenal infiltration, adrenalectomy, and of course, all these drugs like anticoagulant, ketoconazole, phenobarbital, phenytoin, and of course, you got mainly genetic disorders. We gave a great presentation of congenital adrenal hyperplasia with the three major hormones we talked about it, right? Make sure you review our presentation about congenital adrenal hyperplasia. Very, very important topic, okay? Again, I'm just going to summarize one more time. This is happening only over here, below this, okay? In the adrenal gland, primary adrenal insufficiency. Now, we did the primary, let's look at the secondary. Secondary is happening right here, only in the pituitary, okay? That is the secondary adrenal insufficiency. Now let's look at the causes. Abrupt discontinuation of chronic glucocorticoid therapy or any kind of stress. We got pituitary tumors, pituitary surgery, radiation, infections or infiltrates, pituitary apoplexy, Sheehan syndrome, and genetic disorders, okay? That is secondary adrenal insufficiency right here. Mainly the pituitary gland is affected. Now, what is tertiary? When you talk about tertiary, is going up again, okay? This is where our hypothalamus is located. So it's affecting the hypothalamus. So what are the causes for that? You got hypothalamic, any kind of tumors in hypothalamus. So it's kind of very, everybody know that hypothalamic surgery or radiation, trauma, infections, infiltration, anything can affect the hypothalamus, okay? And then, of course, you got drugs, glucocorticoid therapy, antipsychotic drug, antidepressant, all of that can cause tertiary adrenal insufficiency, okay? So one more time, let's look at the classification. We got primary, secondary, and tertiary. Primary, only adrenal gland. Secondary is only the pituitary gland. Tertiary, we come to hypothalamus. Everybody got that? Okay. Now, once we do that, let's look at the pathophysiology of primary adrenal insufficiency. Mainly like what happened in the autoimmune. We already said like number one cause is what? Autoimmune disease, right? So what happens over here, you got stress or virus affect the adrenocortical cells. Next thing happened, apoptosis, necrosis. You have release of peptides to 21 hydroxylase, and this antigen, all of this antigens picked up by dendritic cells, okay? And what do? Once dendritic cell pick it up, it activates with the help of CD4 T helper 1 cells, or 1, 2, 3, 4 actions take place, destruction of the adrenocortical cell happens. Okay, so let's look at one more time right here. So we got stress, virus environment affect the adrenocortical cells, apoptosis, and all these antigens kind of picked up by the dendritic cells. Dendritic cells, with the help of CD4 Th1 cells, activate a lot of things. Let's look at one thing. Interferon gamma activated, interleukin get activated, okay? With the help of CD8, and you got granzyme perforin from the lysozymes, they start attacking the adrenocortical cells. The second one, there is CD4 itself get activated, right? And then you got lymphotoxin alpha, interferon gamma get activated, you got destruction of adrenocortical cell. And then, because of the CD4 Th1, you got interferon gamma, IgG antibodies formation. This is where you have like autoantibodies again. 21 hydroxylase is the common thing we can say, like autoantibodies formation about 21 hydroxylase, and then you got adrenocortical cells. And the last one, there's interferon gamma get activated, macrophages activation, interferon interleukin start attacking the adrenocortical cells, and a lot of damage to adrenocortical cells. Okay, so that is the pathophysiology again, autoimmune or like primary adrenal insufficiency. Now, let's look at the clinical features, like what happened in the clinical features right here. Number one, in hypoaldosteronism, you have hypotension, salt craving, and what happened? You got sodium goes down, increased potassium, right? You can have non-anion metabolic acidosis. Now, let's look at if you have, what are the features kind of associated with the hypocortisolism, right? Because when you got weight loss, fatigue, lethargy, depression, nausea, vomiting, diarrhea, sugar craving, and you got orthostasis. If you look at the labs, you have decreased blood sugar and decreased sodium is common. Now, you got hypoandrogenism, mainly in female, decreased libido, decreased pubic hair. If you check it, DHEAS level is going to be low. And then you can have, because of the increased ACTH, you got hyperpigmentation because you got melanocyte stimulating hormone. You get increased, a lot of melanocyte produced, and the skin pigmentation happens. Okay? Remember that increase. These are the findings based on these facts. Remember that, okay? So you're going to have, because hypoaldosteronism is going to be there, we're going to know hypocortisolism is going to be there, we know hypoandrogenism is going to be there, increased ACTH, and look at all this finding, also look at the labs, like what happens and all that. Now, we looked at the classification, we looked at the pathophysiology, we looked at the clinical features. What's the next thing we have to do? Very, very important. You need to go and look at how do you diagnose it, okay? So if your suspicion is high, then again, you check the cortisol level. Before we check the cortisol level, we need to know a couple of things. After you check the cortisol level, a couple of things can affect the cortisol level. There's something called cortisol binding protein. Okay, so which situation you can have high cortisol binding protein? In pregnancy, you got lots and lots of cortisol binding protein. So what's going to happen to your cortisol level is going to be increased, right? So what happens when you don't have enough cortisol binding protein? Where is all this cortisol binding protein produced? Liver. So what happened in the liver disease? It will go down. So let's say if you have cirrhosis, right, then hepatocellular carcinoma, in those situations, cortisol level could be decreased. So you can have false elevation and false cortisol level in those two situations. Just remember that. Now, the first thing you do, you check the cortisol level, right? We're talking about serum cortisol level. I mean, so the values could be different. You know, if you're in different countries, they might have like different values, but always check with the labs to find out, you know, comparable. This is, we just checking the US standards, what we use in the United States. You can, if you're using salivary cortisol, I mean, the value is going to be different, okay? So if it is serum cortisol, if it is less than 3, very high likely you got adrenal insufficiency. Now, if it is greater than 18, very less likely to have adrenal insufficiency. Next thing you have to do is, you know, we already talked about, it could be primary, secondary, or tertiary, right? So what's the test we have to do is, we do ACTH, you measure the ACTH, and we do something called ACTH stimulation test, okay? Now, if you do those tests, let's say if your ACTH come back greater than 100, and there is no cortisol, right? So what does that mean? So it's no cortisol production, but this ACTH is working, right? ACTH is greater than 100, but you don't have cortisol. That is what does that mean? You got primary adrenal insufficiency. And then we know this is primary adrenal insufficiency. When we come up here, we look at what are the causes. What are we talked about? Number one causes, my friends, what did we say? Autoimmune disease, right? So you have to think about autoantibodies. So you check autoantibodies. So if it is positive, you just label autoimmune primary adrenal insufficiency, right? If it is negative, then you have to look at all these causes, right? We talk about infections, bilateral or drugs, and all of this need to be ruled out. That should be the other thing, okay? Everybody got that. Now, we know this is primary right here because ACTH is elevated, decreased cortisol, okay? Now let's look at, you got less than 10 and your cortisol goes up. So what does that mean? It could be secondary or tertiary right here because you don't have enough ACTH, but this thing is, the cortisol level is increased, okay? So what happens is like, then you can say secondary or cortisol. We know it's happening above this level, the brain. How do we look at it? You have to do imaging studies, right? What is the best imaging study to look at the brain? MRI of the brain, my friends. You do an MRI, you find a lesion, you cut it off, right? Let's say if you don't have a lesion, and then most likely the cause may be like abrupt stoppage of glucocorticoid. But again, you have to look at the other causes. All this thing we talk about, right? All those things need to be rolled out. Now, what is the in order for the secondary adrenal insufficiency, you can always do insulin test, okay? Insulin tolerance test we can do. So a gold standard for secondary adrenal insufficiency, remember that insulin tolerance test. But we don't do that usually because it's kind of a little bit complicated, can affect cardiovascular, sometimes can have seizures and all that. It's a complicated test, so not recommended, but if it is a gold standard, that's a gold standard. So how does it work? And this is again for secondary adrenal insufficiency. Okay, so how do we do this insulin tolerance test? You give insulin. When you give insulin, what happens? You're going to have hypoglycemia. So let's look at over here. This is what's happening. So when you have hypoglycemia, the stimulant go over here. So what's going to happen? Okay, you got CRH or corticotropin releasing hormone goes up, but ACTH will not go up because the lesion pretty much in the pituitary gland over here. Okay, so that is the gold standard. Again, we don't do that, but if you see somebody ask you what's the gold standard, you say insulin tolerant test, right? Now, you can also, let's say if you want to look at this tertiary adrenal insufficiency, right? You want to look at, this is tertiary, what is happening in the hypothalamus? What is the hypothalamus CRH? You can just check that CRH, corticotropin releasing hormone. Again, very expensive test, but you have to do all of this kind of systematic if you want to rule out what's going on. Now, how do you treat it? Okay, the treatment is you have to be, let's look at the primary adrenal insufficiency, right? We talked about right here. What is the treatment? You give glucocorticoid replacement, everybody know that, okay? We usually use hydrocortisone, okay? But when in pregnancy, don't use dexamethasone. Remember that. That's a no, because dexamethasone very potent, and then it can stay in the body a long time, go into the placenta, a lot of complication, right? Steroids and babies don't work well together, remember that. So first you do the glucocorticoid replacement, and you do mineralocorticoid replacement. You can give fludrocortisone, and then adrenal androgen as needed basis, so you have to replace it. Now let's look at how do you treat the secondary, right? Remember, it's over here, those thing, right? You got the pituitary is affected and tertiary. You got the pituitary and the hypothalamus is affected over here, right? So glucocorticoid definitely need to be replaced, everything. But when you talk about mineralocorticoid in this situation, doesn't need to be replaced. The reason for that, renin, okay, that doesn't have anything to do with hypothalamus or pituitary, right? That can come and stimulate the adrenal gland and then continues to produce mineralocorticoids, doesn't need to be replaced. And you replace adrenal androgen as needed. Remember that, okay? And then I already talked about the pregnancy. Just be careful. Don't use dexamethasone. Very careful. Just go back and now let's summarize our finding like one more time. Everybody know that. Let's look at. We know the primary is from here, adrenal gland. Secondary is in the pituitary, and the tertiary is in the hypothalamus. Remember that. And let's think, all the causes we discussed over here. We know the pathophysiology. You got stresses, virus, environment, apoptosis, antigens come to the dendritic cells, CD4-TH1 cell activation, damage to the adrenocortical cells, okay? The best way to look at the clinical features is think about which hormones is affected and what presentations you can have, right? If you have hypoaldosteronism, there is hypotension and salt craving. And you look at the lab, it's going to be decreased sodium, decreased potassium, and non-anemic metabolic acidosis. Now next thing, hypocortisol, decreased cortisol, weight loss, fatigue, lethargy, depression, nausea, vomiting, sugar craving, and orthostasis is very common. Hypoandrogenism, decreased libido, increased ACTH, hyperpigmentation, and there's going to be increased melanocytic stimulating hormone. Okay? I hope everyone read the picture. And now you have to, when you look at the diagnosis, we're going to diagnose primary, and we're going to diagnose secondary, and we have to know it's tertiary also. Okay? The first thing, always check the cortisol level. We are talking only serum cortisol over here. Make sure, whichever country you are, the lab values may be expressed in like millimoles and those kind of things. We're just going by the US standards. So first you check the cortisol level. After you check the cortisol level, always remember pregnancy, your cortisol binding globulin is high, so it could give you high values. If you got liver disease, it's going to be less. Remember that, okay? Now, first thing you measure, if it is less than 3, definitely or highly unlikely you can have adrenal insufficiency. If it is greater than 18, not likely, okay? Then next test, you measure the ACTH and you see to the ACTH stimulation test. And then if you got greater than 100 ACTH and no cortisol, then right? ACTH is working right here. All this thing is working. This one is not working, primary adrenal insufficiency. Then next step is check for autoantibodies. Mainly we worried about 21 alpha hydroxylase. If it is positive, then you say case closed. Number one cause, primary adrenal insufficiency due to autoimmune disease. If it is negative, then you have to rule out all the other causes like infection and all that, okay? Now let's look at the other one. You got ACTH is less, so this is affected right here, right? So it could be secondary or tertiary right here. And then cortisol is going to be normal. Cortisol is increased, no problem. So this one is affected. So they know it's secondary and tertiary. And then you do an MRI of the brain to find out any lesion, right? We already talked about the pituitary tumor right here. So make sure there's no tumor or any other lesion right there. And if you find it, you just resect it. If not, then you have to look at all the other causes. Like mainly you have to worry about the abrupt discontinuation of the drugs like glucocorticoid therapy. And then remember, always gold standard is glucose tolerance test. We don't do because the complications associated with it, like it can cause seizures, cardiovascular complication, and all that. And then CRH test, you can do it up here. You can measure only the CRH test. Then you know if CRH come from hypothalamus, pretty much tertiary, right? And the treatment, primary adrenal insufficiency, and the secondary adrenal and tertiary. Secondary and tertiary, the same treatment. For primary, you got glucocorticoid replacement, and you replace mineralocorticoids, and then androgen as needed. When you come to secondary and tertiary insufficiency, we have to replace glucocorticoid need to be replaced everywhere, but in secondary and tertiary mineralocorticoids, you don't need to replace this because they come from a different pathway. Renin come and stimulated adrenal gland, and mineralocorticoid is going to be produced. Okay. That's all, my friends, in a nutshell, like what adrenal insufficiency is. So make sure you review it, a very important topic for examination purpose and clinical, if you're in clinical practice. Thank you so much for watching. God bless. Thank you.